Hi, my name is Shirley Gutkowski, and this is a presentation about dental hygienists doing an airway exam and why we need to do an airway exam. I am the owner of Primal Air, a practice of oral-facial myofunctional therapy in Sun Prairie, Wisconsin, and we'll talk about contacting me later if you like. But to get right down to it, this is from the study club that was held at Primal Air on April 28th, and this is the rehash of that meeting. And I would like to start this meeting by playing this video here. It doesn't have any narration, but it really is telling and really motivated me from the very beginning when I learned of this video and this whole way of practicing, and why airway was so important and how it got to be so important and such a big problem. video, along with the other videos that I will be showing on this presentation, can be found on YouTube. This one you can find by searching Finding Connor. And I have to wonder how we lost our way, how we in dentistry have really contributed or don't know or haven't been following along closely enough what we can do to manage cases like Connor's and how we can avoid ending up with a case like Connor Deegan. So one of the things that I've been talking about for a really long time is this Dr. Evangeline Jordan, who was one of the first women dentists in the early 1900s. She's also the first leader of the Women in Dentistry group organization. Dr. Phones, who is the inventor of dental hygienists. Dr. Weston Price, who was a dentist who kind of cashed everything in and went on a mission to find out what was going on, and Dr. Pottinger. So let's just start with Dr. Evangeline Jordan's quote that I took from her textbook, Operative Dentistry for Children, that was published in 1925. Not filling teeth, but preserving the necessity for filling teeth should be the dentist's work. Let him consider himself successful who can show a clientele where his patients boast that never from babyhood to the grave have they had a stain or hole in any tooth. That is true dentistry, not this tiresome, painful plugging of holes. It is an ideal possible for the majority of people. Why is our profession permitting 60% to suffer needlessly? So that's from 1925. This here is from Dr. Pottinger, and he did his study also in the early 1900s. Dr. Pottinger found that animals enjoying traditional diets containing raw and unprocessed meats and milk were stronger, more active, disease-free, and socially well-adjusted. And Dr. Pottinger's study is summarized in a video on YouTube if you would like to go to search for Dr. Pottinger or Pottinger's cats. And what he did is he studied groups of cats and fed them 4 different diets. And the cats who were on the raw meat diet and the raw milk diet were considerably healthier than the other cats. The cats on the cooked meat and, not raw milk, let's just say it that way, were horribly sick, and they had really sick babies. They had a high mortality rate, infant mortality rate. They also, the cats who did survive, the kittens who did survive, had even lower mortality rate because they continued on that diet. Their maxilla was never really formed. There's 2 videos on YouTube, and in one video, the skeleton of the cat was kind of laid out in an explosion style, if you know what I mean. And you can see there are parts missing of these adult cat faces. The worst part was that it took 2 generations to get those cats back to health. And that's saying a lot considering where we are right now today. And now that we know about epigenetics and how the environment of a woman will affect her grandchildren and later is really important information. And the grandfather's environment from the time he was 11 or 12 or so also affects those grandchildren. So it's really important for us to really get to the bottom of this as soon as possible. Dr. Price is a dentist who couldn't get over this drilling and filling. And if you talk to dentists very often, you'll find that there are a lot of dentists who cannot do this drilling, filling. It's a total, rat in a cage kind of a thing on a treadmill or something. Every year they just keep drilling and filling, and it's just disheartening because it's just never ending. For me, I'd like to say it's like doing dishes. Every time you figure you're finished and you let the water go, somebody comes up with another glass. It's just always something is just coming up. So what he did is he sold everything and went on a worldwide excursion to find out what happened. And he went back into the back countries and into native tribes that hadn't been exposed to Western civilization, in air quotes. And he found that those tribes who were still eating their original diet of food did not have dental decay and did not have crowding of teeth. And when he went back after a generation had been on the Western diet, he found that in one generation there was crowding, dental disease like cavities, and periodontal disease. And he also found that diabetes was also starting to creep in. So when we think of even the Pima Indians here in the United States and their level of diabetes in that group, really should not have, that group of Indians, or Native Americans, I guess is more accurate, could have never survived had they had diabetes at the rate that they do today, back then, back in the super olden days. And so it's important for us to really get a handle on that. And it's not just about GMO, it's about the whole of it. It's about the way that different people in different latitudes on the globe are eating and had been eating. They eat what's close to them. And what we have now is people who have traveled the globe and have had children. And so we have, people in the latitudes that were closer to the equator marrying and having children with people that lived up in the North Pole. And how are those children supposed to eat, and what food is supposed to be helpful for them? It can't be a vegan diet, or can it be? I don't know. So I'm really thinking that this whole diet thing is going to be only managed by DNA testing, so that we know what predominantly kind of food that person should eat. So that kind of comes from Dr. Weston Price and his studies. And Dr. Phones is the inventor of dental hygienists. And he was also tired of drilling and filling. And this idea of germs causing cavities was really moved forward about the time that he graduated from dental school. And so he trained his dental assistant, Irene Newman, to clean his patients' teeth, because it was impossible for hygienists to go door to door to do this. So the idea was that these hygienists would work in public areas like a school to prevent decay in the children, and also be in a dental office. So today we have dental hygienists all over the place, but they're really trapped in a dental office, and they can't go out due to most of the laws in the United States. But the point is that everybody at that time in the early 1900s was finding out about the same thing, and really we don't have any answers. This is a little graph here that I stole from another YouTube video. This is Dr. Mike Mew, M-E-W, and he shows this graph in that video, and found that the history of malocclusion really started when we started to do different things with our diet, and how it really ramped up. You can see there, right here at about the 1900s, it's just like a straight up line. That's when food started to be really, really different. Our cooking was different. By 1900, we were shipping and training and trucking foods from hither and yon, and the quality of the food is questionable, even though it looks really nice. The blueberries from 2,000 miles away don't have the same nutritional concentration as blueberries that were 100 miles away. So it's that kind of thing that really is starting to all come together, and because of the internet and because we can share this in different places, we're really helpful. This idea is really helpful and it can move faster forward. The idea here centers on the size of the maxilla and the size of the mandible. So they are both shrinking, but the shrinking maxilla is of higher consequence than the shrinking mandible. So you can see here this green area is all the maxilla. So this area here in the front where we're all used to seeing it, but look, it even supports the eyes. It goes way back there. And because of the lack of chewing that we have today, we don't have to chew our food. We can just kind of mash it around. And because of the nutritional density of the food, it is creating an entire different environment for that maxilla. It's not required to grow. And if our grandparents weren't chewing because they were already eating a diet that wasn't nutritionally dense and it was already processed and there wasn't a lot of chewing necessary, we are having a smaller and smaller maxilla. Part of that maxilla problem is coming because we're able to survive a tongue tie. We have ways to get around nursing and the painful nursing that happens when a child has a tongue tie. And the tongue tie is important because if the tongue doesn't get up into the palate, there are no opposing forces against the cheeks, and that also contributes to the palate becoming smaller. I'd also like to point out right at this stage that the maxilla is also the sinuses. So the roof of the mouth, which we always think of as the maxilla in dentistry, is also the floor of the sinuses. So that's an important distinction. And the people who are studying the maxilla, I know it sounds weird, they're finding that the maxilla has shrunk in the last 120 years or so, the same as it would have shrunk in 10,000 years if evolution were to just normally carry on. So we're forcing this change. This is another video here that I'm going to let you just go to find. This is on YouTube. This is a dentist who is down in Louisiana, Colquitt, I think is how you say his name. And he was sick as a child. He was extremely sickly as a child. And in his 70th year, he decided to take the information that was coming to him in the recent past, for him at the time, which is maybe 2 years ago, and he decided to have his maxilla expanded. Now, you'll see a lot of controversy that you can't expand the maxilla in an adult. Well, his maxilla was expanded. He took serial photographs from the beginning of his treatment to today, and he has an overlay of a 3D image that shows the amount of bone that was grown over the time that he was wearing these appliances to increase his airway. And then he goes through all the things that he doesn't have anymore because his airway has been expanded. And then we have things like this is our gold standard answer to an obstructed airway or to sleep apnea, and that is the CPAP. Only half the people who think they should have a CPAP or think they should have a sleep study go for a sleep study. And only half of the people who are prescribed a CPAP machine even wear it. So it's a pretty small percentage to be calling it a gold standard. We have studies to show that that mandibular advancement devices also improve airway and stop snoring, but it's still just a symptomatic thing when we could be doing more for it. This article here from the Washington Post was really kind of telling. I like to highlight these two sections here that he was obsessed with detail. So this Supreme Court justice here, is obsessed with detail, but they found that his CPAP machine was unplugged next to him at this ranch or wherever he was staying. It wasn't plugged in and it wasn't turned on. And so now they're thinking that maybe he forgot to use it that night. And I can tell you for sure, I haven't talked to anybody, obviously, but it's very much more likely that he was so happy his wife wasn't there to boss him into wearing it. And maybe he had an extra glass of wine and just thought, oh, screw it for tonight. And he just never woke up. So this is a problem. Reggie White also died of sleep apnea. His CPAP machine was also not attached. So this is a problem, and it is a life-altering problem. Pardon the pun. We have two ways to have a smaller airway, obviously structurally, and there are two ways to have sleep disordered breathing. The classic one that everybody talks about that's pretty deadly right on the face of it is the sleep apnea, where you stop breathing for periods of time, even up to a minute, while you're sleeping, and then reawaken in order to gasp for air and then continue on sleeping. The other is an obstructed airway with just an allergy profile, or that it's just small, which is the structural way. Allergies can cause the airway to become smaller because it's just filled with mucus. Enlarged adenoids, tonsils, the tongue tone, and a smaller palate all contribute to these airway obstructions. And by a dental hygienist noticing these things at a very early stage, obviously is better. And noticing it in your patients who are not responding well to medical treatment or have no improvement in their dental treatment, we have a bigger part to play in healthcare than we really appreciate. So while you're doing your oral cancer screening, or maybe before you lean your patient back, take a look in their throat. So this is the Friedman palate score. There's also the Malampati score, which is very similar, except that the tongue is sticking out when you do this exam. Look to see how much room there is for the airway to go from here. This is very telling, okay? So you can see this person here has very much less airway visible. This is much less airway visible, and this is none. Now, the way that these pictures look, it almost looks like the tongue is growing. The tongue is not too big. The tongue is never too big. It's only too big if it hangs out of the mouth, and that's a separate condition for something else. There's no such thing as a too big tongue. Macroglossia is not a condition that a person who walks into your dental treatment room is going to have. So this is an airway issue. It could be a maxillary size issue. It could be a couple of different things, but this one here is a good score to use right off the bat. It's non-invasive. You don't have to tell your patient what you're doing. You can just look in there and see what's going on. Another one is a high narrow palate. And we now know that that is a sign of obstructive sleep apnea. So now when we're doing our initial exam and we write high narrow palate and then we never ever address that, we can now. Since 1997, as a matter of fact. So here we are 20 years later. And we have to do something about it. It's been known for 20 years that a high narrow palate is a symptom or a sign of sleep apnea. So it looks like this person here is kind of young. Maybe their premolars are just barely coming in. You can see they already have cavities or at least fillings. So a little bit of gingivitis over here. This is a symptom. It is a sign of obstructive sleep apnea, and this we can bring to our patients. We can say, do you snore? How do you sleep? Tongue tie is also a really important feature here. This tongue is tied This patient can't reach their tongue up to the palate behind the upper front teeth. This is another sign of a potential for sleep apnea or restricted airway. It certainly is a condition that will perpetuate a high, narrow arch. It's another person with a tongue tie. I saw a person a couple of weeks ago in their middle 50s with a tongue tie that was almost this severe. You would wonder how he got to be 50 middle years old. But he can talk and he can eat, and that's the only thing that anybody ever thinks about. But what he had were symptoms that he was taking medications for, and he was not interested in having that surgery. I can't imagine why. It's very, very simple. It's not expensive. It's not debilitating. But for a person to have a tongue tie release, they really do need to see a myofunctional therapist to get that tongue exercised and start learning how to use the tongue before the surgery, and then for a couple of weeks after, to make sure, for one thing, that this tether here doesn't reattach in the same spot. This is how the tongue can move between appointments, pretty much. So this tongue was released right here, right? You just use a laser for the most part and have that released. For you to do an exam to see if it is truly tied, if you right now open your mouth as far as you can without, jumping your TMJ, and then trying to touch your palate right behind your upper front teeth, right in the incisive papilla area, with your mouth open. And you should be able to do that without closing your mouth 50%. So your mouth can close a little bit, but every little bit that you have to close is a little bit more tied. So if you have to close over 50%, then that is definitely a tongue tie. This is a case of tongue tie release by Dr. Bill Hang, and you can see that this arch is already expanded on its own in a child. Now, can a tongue do that in an adult? It's unlikely. People are still nervous about saying that. They need to have a little bit of help for that to happen as an adult. But in a child where everything is still moving and growing and transferring and blah, blah, this is the perfect time to do a tongue tie release. It's the perfect time to do a tongue tie release because the tongue can do half the work. This is another test for tongue function, is to have the patient move their tongue from side to side and make sure it reaches from side to side, and then see if they can reach all the way back to their molar, to the last molar on the upper arch. And then ask if they can do this clicking sound. If they can't, then there's very likely a posterior tongue tie where there's a tissue holding the back side of the tongue down. It's not as visible, it's not as known about, but that's another way that you can test to make sure that the patient's tongue is working. Okay, so here's a horizontal test to see if they can get their tongue all the way up. These are the different freedom classifications. The normal is where the tongue can maneuver around all over the place. An anterior tongue tie is where this frenum is more towards the tip of the tongue. We have the short frenum where the tongue just can't lift very high. We have the short and anterior. And then we have total ankyloglossia where it's tied almost to the tip and you really just can't do much with the tongue at all. This is what we usually learn about, right? Ankyloglossia in dental hygiene school. Well, but it was for me, I guess. And then then you mark it down, and that tie should be released. But what we really need to know is that even these kind of ties should be released. The tongue needs to move all over. The tongue is kind of the rudder of the body. And mouth breathing is a symptom or is caused by a tongue that doesn't reach into the palate. The patient has a smaller arch, as you can see in these pictures here, and that is impeding the nasal airway breathing, nasal breathing. And by doing that, you're forcing the jaw to hang open, putting stresses on the temporomandibular joint. And that's not good either. So we want to avoid this long face kind of a look. This picture here, this first picture, is a girl that could have been addressed possibly when she was 3 or 5 years old. There's a very famous study that Dr. Mew talks about in his lectures, and so does Joy Moeller. The patient whose parents bought him a hamster at age 10, and the hamster lived in the boy's room, and the boy was allergic to the hamster, and how his entire face structure changed because he was then forced to breathe with his mouth open. So that's really important. We know that over 27% of children snore when they're sleeping. This may look like they're just relaxed, but you have to really put 2 and 2 together and wonder, is the airway blocked? Are they really relaxed, or can't they breathe through their nose? My son is in his middle 30s, and he was sleeping on the couch, with his head back. Most of the time, his mouth was closed, and just as I was getting my camera to show how he could be so relaxed and breathe with his mouth closed, his lips parted. So he's not really a kid, and I don't remember my kids snoring, but I do remember that they had a lot of trouble. Well, they had trouble sleeping. They had trouble being asleep. Our oldest child especially used to fight falling asleep like nothing I've ever seen since or before. And he does have a sleeping problem even today. The symptoms of sleep disordered breathing are associated pretty strongly with ADHD, ADD, and behavioral problems. This was a study from 2003 in pediatrics that looked at over 3,000 5-year-old kids and compared a snoring group with a non-snoring group. And they found the kids with snoring had daytime sleepiness, okay, but they also had behavior problems, including hyperactivity. They had inattention, and they had aggressiveness problems. So those children that you hear about, or that are in your treatment room, or the sibling is being aggressive while you're cleaning the other sibling's teeth, those kids may have an airway problem, and it deserves more scrutiny. Symptoms of inattention and hyperactivity in children with habitual snoring. This is from Istanbul. I know our kids are way different than the Istanbulian children, but it's a worldwide phenomenon. This study was published in 2005, and the teachers observed significant correlations with learning and disability and the level of academic performance in children who snored habitually. So this isn't just something that happens in 1 or 2 kids. This is a big, big problem. Neurological effects may be irreversible. Dr. Gelb talks about, he's a dentist and the developer of the Gelb appliance, dentist in New York City, and he talks very strongly about the idea that orthodontists should see children at about the age of 3 so that we can make sure that they're reaching their cognitive potential. So that's really something that we need to be thinking about. The brain develops pretty dramatically by age 3, and if the child is suffering all night long without oxygen or throughout the day breathing with their mouth open, we're losing a lot of ground at that young age. Symptoms peak at 30 months. So there was a 40 to 100% increase in neurobehavioral problems at age 7. So we need our kids to be breathing. I mean, who would think that you'd have to actually say that? This was, I think this is that same study. Yep, in 2012. By age 4, the snoring kids, 20 to 60% of the kids were snoring. By age 7, up to 100% of them, and 200% increase in hyperactivity was noticed. Now, I have to say that I had a conversation with a dentist a couple of months ago about his own child and his child snoring and his attempts to get that child's tonsils out so that the airway would be improved. And so he was talking about how it took him a month or 2 to get her in to see an ENT. Then the surgery was scheduled because she did need to have her tonsils out. They were interfering for 6 months, and then she had a cold right then, so they couldn't do the surgery, so it was another 2 months. So it's almost a year from the time he had determined that she should have somebody, take those tonsils out to the time where they were out, and the situation had resolved itself. So am I saying wait and see for a year? No, what I'm saying is that there are ways to shrink tonsils that maybe nobody's talking about. And the most important way and the easiest and cheapest way is to use a xylitol nasal spray. So when I told him that, he was like, studies, studies, studies. And so, of course, there aren't any studies because people who are using this are just using it. And what xylitol does in particular is eliminates the strep bacteria, which are the early colonizers of biofilm. And when we have strep bacteria, like strep pneumonia, which is the cause of ear infections, strep mutans, which has been linked strongly to dental decay, and all the rest of the strep, there's hundreds of different streps, and they all start those colonizing early, and they pump out this mucus that traps all of the other biofilms in it, and it's an active entity, this biofilm. It's not just like sludge that collects up other stuff. So the xylitol affects those early colonizers. The body produces just enough mucus to trap the allergens that are in the air, and the xylitol then also helps to rinse things down and away. So it just keeps everything moving, especially up here in the winter. It's crazy in the northern climates here during the winter how dry everything is and how hard it is to get good oxygenation. So I know that there's an orofacial myofunctional therapist who is writing an article for RDH magazine. Hello, get it done. About her use of using xylitol nasal spray in her clients that have airway issues and tonsils and adenoid problems. So that's an important thing to understand, that you can do more. And dental hygienists are in love with xylitol products anyway. So if we can recommend a xylitol spray, we're doing so much more for our patients. Child has ADHD. They have 8 times the incidence of learning disabilities. They have 8 times the incidence of anxiety and 3 times incidence of low social competence because they're starving for air all night long and they just don't develop the executive functioning part of their brain. So we need to make sure that these kids are breathing. Obstructive sleep apnea in this study mimicked attention deficit disorder. This is a case study that looked at one particular client, a 17-year-old who was not snoring, who presented with prolonged history of 4 complaints: inattention, fidgeting, frequent sinusitis, and somnolence. So what I found is that, somnolence is sleepiness. So that's where that comes from. He was diagnosed, of course, with ADHD, and his somnolence, which was the telling feature here, abated somewhat when he was on antibiotics for his sinusitis. Okay. A later sleep study revealed obstructive sleep apnea and through additional testing proved that the original ADHD diagnosis was in error. So we need to get rid of the mouth breathing. We need to get the maxilla expanded. We need to do more just by doing an exam. What are we looking for? We're looking for airway. We're looking for people that have potential problems. We want to see a nice face that isn't forced to hang long. We want to see an airway that's bigger than this. This one doesn't even look problematic, but look how nice and big this side is over here after using the arch expansion device that Dr. Hang had developed. So when we're looking at our health history, this should be one of our first, hey, wait a minute, moments. You wouldn't necessarily wonder about this patient. They have migraines and gastrointestinal disorders, headaches, but you have to look at that and go, what do these things have in common? Well, it turns out that they maybe have more in common than you thought, because GI disorders are also affected by sleep, disordered breathing, and low oxygenation. This is the chart of that person, and you can just see how much dentistry this person has had. This should be an alarm. I really don't know how dental professionals can look at somebody, have this kind of a treatment plan at that age, and be okay with it and just give them fluoride and ask them to floss more. I think that's just terrible. This should be alarming. This should be gut-wrenching, and this should be making you ask for more information, making you ask more questions. That person had an anterior open bite, class 3 occlusion, low tongue because it was tied, was short and anteriorly tied. They had speech impediment based on that tongue tie, and they had a hypertrophic mentalis, which means that they were swallowing incorrectly. So that's what was happening to that patient. So all of those things, plus, plus all that cavities, those are the things that were causing the problem. This soft tissue part that's never addressed, almost never addressed. That person also had a classic mouth breathing kind of a picture. Most people won't tell you that they are mouth breathing because they do have a bad reputation. That meme that I showed you with what's his name from the Family Guy, Peter, whatever I guess is his name, and he. I looked at a lot of memes that were very, very snotty about mouth breathing, and that was the least objectionable one. But we do look at people who are mouth breathers, and we do make snap judgments based on their mouth breathing about their intelligence. It's not fair, it's not right, but that's what happens. Also, when you're doing an exam, look at the tongue. A scalloped tongue has been associated with sleep apnea. It's not associated with grinding and clenching, not so much, except to say that the clenching and grinding may be a way for the patient to wake up in the middle of the night so that they can breathe. So if you're grinding and clenching your teeth all night long, you're not reaching your sleeping potential either. And that may be why the scalloping is so associated with clenching and grinding. But the clenching and grinding cause is the airway problem. It's not whatever stress you had or did you drink too much or not enough. It's about the airway. Everything seems to be coming from the airway. So when you see people like this in your case, go and look further. Ask more questions. Look further. First question, how do you sleep? Do you snore? Does your wife say you snore? Have you ever had a sleep study? If you haven't, the first thing might be to have a sleep app from your phone to lay right next to you so that you can monitor your sleep apnea. We have tools in orofacial myofunctional therapy to help expand the maxilla. Dr. Mew talks about having all of his, when he sees a 4-year-old or when he knows that there's a 4-year-old in the family, that 4-year-old is asked to chew gum for an hour a day to get that maxilla exercise, to make sure that it grows, and he's been finding really good success with that. This is a little gadget for breaking the tie for the lips, so that the lips can be more relaxed and so that they can exercise the lip using that little pull chain, and that's to be done multiple times during the day. So there we have it. There's the dental hygiene exam. There's the reason to send patients to an orofacial myofunctional therapist and have their sleep evaluated or their orofacial myofunctional disorders evaluated and treated. And that's what you do as an orofacial myofunctional therapist. But it really centers around the dental hygienist exam and what is the dental hygienist doing and how is it working for them. It's not just about teaching patients how to floss or putting fluoride on their teeth. They really need more from us. We know that dental hygiene treatments save money, and we knew when this story broke about periodontal disease and systemic health that we were saving lives potentially, and now we know that we have another way to save another life, and that's more easily understood by patients. You know, they don't always get this connection between gum disease and heart disease and the traveling bacteria and all that stuff, and the inflammatory response. But when you tell them that they're suffocating all night long, they get it, because everybody knows that people need air. So this was the Dental Hygienist Study Club for April 28th, 2016. My name is Shirley Gutkowski, and I appreciate your attention, and I hope to see you soon. Thanks.